Hello, everybody in the room, and hello, everybody back online again. So I'm chairing this session. Unfortunately, Dr. Anna Francis, who is one of our paediatric nephrologists, was meant to be chairing this and has got a much better offer of some other meeting, and unfortunately can't be with us right now, but has been very much with us for much of the day. So I'm chairing this session, and I'm really delighted to be able to start it off. So first of all, I'd like to introduce Ms Leonie Wilcox, who's the manager of the ANZTCT Registry. The registry was established in 1992 and initially funded by charity. It's evolved to a clinical quality registry with Commonwealth funding and now includes CAR-T data for regulatory compliance. Leonie advocates for accurate, efficient data collection as a foundation for improving healthcare. Please welcome Leonie.
Thank you to the organisers for inviting me. I feel very unscientific compared to the rest of the speakers for the day, so I'm going back to basics. Talking about data, the 4 A's of why we need data. I stole from Mary Horowitz. If there are any BMT people in the room, they will know who Mary Horowitz is. She is one of the founders of CIBMTR, which is the huge registry and research group in the US. So yes, and I think everybody will agree we all need data for those various purposes. I'd kind of like to sow the seed at this stage to say that randomised controlled trial cost a bomb and may not even answer your real world questions. So if there is a registry around that could answer your questions, please feel free to reach out to them, because I think we need to be smarter about how we use data. So for the purposes of my talk, my version of transplant is only BMTs and stem cell transplants. So when I refer to transplant, I'm not talking about all those kind of things that you've been talking about all day. So BMT people have got together around the world for a long time, recognising the need for collaboration in this field. And the British and Irish Registry, which is similar to us, and where Australia and New Zealand, there, UK and Ireland, they have about 50 centres, 60 centres, I think. We've got 50 contributing centres around Australia and New Zealand. The EBMT, on the other hand, has been going for 50 years. They had their 50-year anniversary last year. They have 50 contributing countries, so they're huge. And the good thing about this network is that the data collection is all harmonised, so that where everyone around the world is speaking the same languages with regard to this data. Australia was a little late to the party recognising the value of registries, but we now have a division in Canberra called Australian Commission of Safety and Quality in Healthcare, and they have a clinical quality registries program that started around 2010. And so that is making the use of data, of routinely collecting data for a self-improving healthcare system. And the thing about randomised control data is it's often expensively collected and then tossed, whereas this data hopefully can be routinely used and shared. That's the aim. We're not there yet, but the aim is to share data for a self-improving healthcare system. And that there's a framework, there's a strategy there. The new version of the framework came out last year, so it's on everybody's radar that how we've been using data is not the most efficient. We're clearly not up to speed with, we haven't caught up with technology. The technology is way ahead of the governance. So for our registry, as Julia said, we started in 1992. We ran on charity and volunteers for a while, got Commonwealth funding coincidentally around the time they started recognising the value of clinical quality registries. We were sitting at St Vincent's Hospital on a spare computer in a cupboard under the stairs for a while, but we've outgrown that. And this year, the professional body, the ANZTCT, has taken over operation of us. So we are totally, we're employed by them now. We're nothing to do with the hospital. So we're quite independent and autonomous, and it's can be great. So that's just our cash flow. So our Commonwealth funds come via the donor registry for historical reasons. We now collect CAR T data as MSAC approval for reimbursement of the CAR T products. The companies have been directed to negotiate with us to collect that data, and that's in line with all those other overseas registries that I'll showed you before. So we've got those two main sources of funding, and now, as I said, we sit autonomously. So here's what our data looks like. We have about 2,000, I think there was 2,300 transplants in Australia and New Zealand last year. I'm sorry, my data is a little out of date because in the process of disentangling from St Vincent's, our data was held up. So I haven't had access to our data for a few months. We have it now, so things that we'll be looking up, but this is, apologies for being a little out of date. So we historically now, we started off quite small, but transplant numbers have increased. And we now have, it's probably 900 to probably 1,000. And so I was interested in Stephen Boyle's talk this morning. He said that there's more than 10,000 CAR T treatments worldwide. So we've probably got about 1,000 of them. So we're up there for the size of us, I think. And one of the complicating issues is that about half of our CAR T patients are also our transplant patients. So it makes sense that we monitor those as a patient journey rather than as a single instance. Here's what we do with our data. So the funnel plots you probably recognise for benchmarking and quality purposes. And the graph on the right is showing how the data set has grown. So while activity figures, the counting patients is kind of interesting at 2,000 a year, the real value is the long-term follow-up and watching the changes over time. We've been, we expect to be following the CAR T data for 15 years. They along the lines of abdominal mesh and breast implants and other treatments that were not followed systematically. I think it's important that we monitor CAR T. And also transplant long-term complications have also, because people are surviving longer, just monitoring their quality of life for longer. So it's that bulk of patient years is important for us to monitor. Here's a snapshot of 2023. We have about 50 centres around Australia and New Zealand. The auto transplants are shown in red and the allo in blue. So you can see that our centres vary from small centres that do a handful of auto transplants each year to large centres that do a lot of allo transplants. And up to more than 160 in one centre in 2023. Not allo, that's a mixture of allo and auto. Also on that graph, it shows the little diamonds are the CAR T treatment centres. And since that time, there's been another, I think 3 centres have come on board, but there'll be a gradual increase, especially as myeloma CAR T comes on board. I was surprised to hear that some people are thinking it's going to be next year. We were thinking sooner than that, but we're expecting more centres to be able to do CAR T. And the other thing I've shown on that graph is the green dots, which are FACT-accredited centres. And one of the other reasons that the BNT people around the world collaborate and harmonise is because there's a lot of countries actually mandate international accreditation to be able to perform those procedures. Australia does not, but you'll notice that most of the centres that do CAR T are FACT accredited or working towards it. And New South Wales has, in fact, made that a condition that if centres are going to be if they're going to be given CAR T role, then they will need to be FACT accredited. So FACT accreditation requires a lot of extra scrutiny from the whole of the process, from the clinical, the laboratory records, training records for staff, data managers, and so it's a lot more scrutiny than just the normal Australian hospital accreditation. I particularly like that there's a section on data management because a lot of hospitals don't even have a data manager. They just have somebody do it in their spare time. But data management, it recognises the importance of having the data that can be used for accreditation and comparability across the world. Now, for this audience, you may be more interested in the transplant-related mortality, and that has improved over time. The graph on the left, so this is just the paediatric cohort. The graph on the left shows the various kinds of donors and the transplant-related mortality, and that is usually defined as what happens in the first year, or the highest amount of it occurs in the first year. And you can see that in the earlier cohort, the graphs were higher. Sadly, in the 2023 report, there's not a lot of difference. We seem to have plateaued with TRM, and it's pretty much the same story in the adult cohort, that there's not as much of an improvement in TRM. So why is that? So in the paediatric cohort, most of the, around half of the patients dying from an allo transplant in the first year, it's because of their disease relapsing. But if you break down just the TRM component of those patients dying in the first year, infection is a big contributor. It's difficult in our cohort to tease out whether it's graft versus host disease or infection because they're often together. So we collect all contributing factors, but infection tops the list each time. And for the adults, the TRM is worse. So at the allogeneic transplant for the adult population is tougher in the first year. And once again, it's infections that's the leading cause of the contributing causes of TRM. Just showing you a bit of CAR T data. The CAR T data we haven't had access to because it's been locked at St Vincent's. So this was only up to our ASM in September last year. Since then, those numbers have increased a lot, I believe, because CAR T is now available for second-line treatment for NHL. This is just an interesting plot. Well, I found it interesting. It's a CAR T treatment costs about $500,000. An allo transplant costs, I don't think they've done any recent costing, but it's several $100,000. This is a cohort of patients. What it doesn't have there, I managed to cut off, is that of those 44 patients who had CAR T, 25 of them had previous allo transplant. And so there's a few of them that have gone to have 3 CAR T infusions. 14 of that 44 had a subsequent allo transplant after their CAR T treatment. So it's very expensive, and that's why we're monitoring them. This one I just threw in because it's interesting, because I want you to use your registries. This is the kind of thing that you can do with registries. We really like denominators, and it's really nice to know where everybody's from, so we can direct resource allocation or whatever. So CAR T, there's still quite a few people that aren't even managing to get getting their CAR T infusion in their own state. This was a data dump, just to show you. We do have this information if anyone wants to do a deep dive into our CAR T data. we've got all the infections that they've had along the way. This is only in the last few years, obviously. But as far as the cause of death from CAR-T, it's more likely to be the disease and a handful of infections, but bacterial infections seem to be topping that list. Amy referred to Julian's work before. This was Julian's PhD study talking about infection-related mortality after transplant. And I put that there because it's obviously a gorgeous slide, but just to show the difference and that there's multiple causes of the of infectious deaths, but the profiles for adults and children are quite different. Anyway, Julian's paper for his PhD was really interesting, and apparently Fred Hutchison, George Stoll, and him for good now. So for the future, it would be great to have appropriate governance and ethics for registries. At the moment, we're putting in the same kind of ethics application to run an observational registry as you do for a randomised control trial with an intervention. That doesn't make sense, but that's on people's radar. We need to streamline data flows. You can't be giving the same data into multiple different places. That's a waste of everybody's time. We contribute to those overseas registries as well. So it doesn't make sense to be sending the same data to multiple places. You need to know what your data's about. So I was talking to somebody earlier talking about you put your data in and then sometime later you'll get, oh, you've got this in there. You need to be able to see what's in there so you can make sure it's good. Automated data quality checks and reminders are kind of happening. One of the biggies, though, I think is simplifying linkages to facilitate research. So if you're doing a transplant study, we've already got most of the data you're going to be collecting, so why collect it all over again? Our transplants have multiple indications. So we've got MS, we've got AML, we've got a lot of different diseases that have their own disease registries. So rather than trying to work out the details of the diagnosis and their outcomes, we should just be linking. And we have done a linkage with AML and we have been working with MS, but it needs to be smarter. We need to not collect the same data multiple times and use it. And of course, linkage to administrative databases, especially for costing studies. So I think we're getting there. I'm hoping that we'll be a little bit closer. I'm not sure it's going to happen in my working life, but I'd like to get there to shortlist some of it. So thank you to first of all, our contributors and our funders and the Maribel Foundation, which has basically been supporting the registry since 1992, one way or another. So fully supporting it to start with. And it still does things like supports data manager education and nurses education, a lot of things. So there's been friends for a long time. Yeah.
Thank you so much. A really good introduction and illustration of the huge value of registries, which is the theme of networks and registries of this session.